Have your worst IBD flares ever pushed you into the ER? And would you change course if a single nutrient cut those visits nearly in half?
Welcome to Dr. Mercola's Cellular Wisdom. Stay informed with quick, easy-to-listen summaries of our latest articles, perfect for when you're on the go. No reading required. Subscribe for free at mercola.com for the latest health insights.
Hello, and welcome to Dr. Mercola's Cellular Wisdom. I'm Ethan Foster. Today we're examining how vitamin D affects inflammatory bowel disease, why higher levels are linked to fewer hospitalizations and less steroid use, how it influences inflammation and your gut lining, and the practical targets you can pursue.
I'm Alara Sky. You're going to hear specific numbers from recent research, how children and adults respond, and what a tailored strategy looks like. We'll stay with the evidence and keep recommendations limited to what the article states.
Let's start with outcomes that matter to you. In a Veterans Health Administration analysis of 5,021 adults with IBD tracked from 2000 to 2023, vitamin D supplementation was associated with a 53% lower risk of hospitalization, a 25% reduction in corticosteroid use, and a 34% drop in emergency visits. Those benefits showed up in Crohn's and ulcerative colitis and persisted over time, especially when deficiency was corrected.
That adult data pairs with findings in children. A meta-analysis of 4 studies covering 224 pediatric patients reported that higher dose vitamin D improved blood vitamin D levels and lowered ESR, an inflammation marker, but did not improve remission rates or meaningfully shift CRP. The improvement is real, but remission itself didn't change in those trials, reminding you to view vitamin D as support, useful, not singular.
Mechanistically, you have several levers working at once. Active vitamin D binds its receptor, turning on antibacterial defenses and inducing genes such as defensin beta-2. It also upregulates NOD2 expression, further enhancing antimicrobial activity. These actions help you limit harmful microbes that agitate flares.
Barrier integrity is another target. Higher vitamin D levels promote expression of tight junction proteins, ZO1, Claudin-1, and occludin, helping you maintain a sturdier mucosal lining. Stronger junctions mean less translocation of irritants, fewer inflammatory cascades, and greater resilience between flares.
The immune balance shifts as well. With adequate vitamin D signaling, pro-inflammatory mediators like TNF-alpha and IL-17 decline while IL-10 rises. That recalibration helps you avoid the exaggerated responses that keep symptoms simmering and push you towards steroids when flares break through.
Your microbiome sits in the middle of all of this. Low vitamin D correlates with dysbiosis, while repletion supports commensal bacteria that generate short-chain fatty acids such as butyrate. Those metabolites reinforce your epithelial barrier and suppress pro-inflammatory signals. At the same time, vitamin D increases antimicrobial peptides like cathelicidin and beta-defensins, tilting the terrain away from opportunists.
Clinical trials aren't identical, and the review makes that clear. Supplementation consistently raises blood levels, but symptom results vary. Some trials show fewer relapses and better disease activity indices. Others show limited differences. A key pattern emerges. Earlier intervention and correction of marked deficiency tend to deliver the most meaningful benefits.
That leads to tailoring. The strongest results come when you adjust supplementation to your baseline deficiency, disease location, absorption capacity, and individual factors. Instead of a one-size-fits-all dose, use steady, personalized strategies, daily or intermittent, aimed at achieving and holding sufficiency while you monitor your response.
Targets matter, and the article is precise. Aim for serum vitamin D levels between 60 and 80 nanograms per milliliter. To do that safely, prioritize sensible sun exposure and support supplementation with magnesium and vitamin K2. Testing isn't optional. Regular checks confirm whether you're in range and help you avoid both deficiency and excess.
Sun guidance in the article has a timing update. You're advised to favor morning or late afternoon exposure and limit midday until you've reduced linoleic acid accumulation in your skin. The concern is that ultraviolet light interacting with embedded LA may trigger inflammatory reactions that increase sun sensitivity and damage.
There's also a strategy to accelerate clearing LA from your tissues. The article notes that C15:0, penadecanoic acid, can shorten the timeline from roughly 2 to 3 years on a low LA diet to about 12 to 18 months. A personal intake of 2 grams daily is mentioned, while most people obtain only 100 to 200 milligrams from dairy. The point is to raise C15:0 to speed replacement in skin cells.
If you consider supplements, dose follows data, not the other way around. The guidance is to adjust vitamin D intake based on your measured blood level, not to take high dose by default. The article warns that excessive dosing can be toxic. Think vomiting, increased thirst, and kidney injury. So bring magnesium and vitamin K2 along to improve utilization and assess levels as you go.
Retesting closes the loop. Recheck your vitamin D in 3 to 6 months to verify that your sun plan and/or supplement routine is moving you toward the 60 to 80 nanograms per milliliter range. Use that result to fine-tune the approach, with the understanding that absorption, disease activity, and season can shift your needs.
For parents navigating pediatric IBD, the takeaways are consistent. Higher dose vitamin D improved vitamin D status and lowered ESR in the pooled studies, but did not increase remission rates. Use vitamin D as a supportive element within a broader management plan, instead of expecting it to act as a standalone fix.
Stepping back, the message is practical. Correcting low vitamin D tends to reduce relapse risk, strengthen your gut barrier, and reduce reliance on steroids in acute care. It's most effective when you individualize dosing, coordinate with cofactors, and verify progress with regular testing rather than relying on assumptions.
Here's your challenge. Schedule a vitamin D blood test within the next week. Set a personal target of 60 to 80 nanograms per milliliter, and map a simple plan: morning or late afternoon sun, magnesium and K2 support, and an evidence-based supplement dose that respects your baseline. Retest in 3 months to confirm you're on track.
Thank you for watching Dr. Mercola's Cellular Wisdom. We'll see you on the next episode.
Thanks for watching. Subscribe now and click the notification bell so you never miss an update. See you in the next video.